Good morning, everybody, wherever you logged on. I have the privilege to share and chair this webinar, actually alone because Augusto, Zani, our co-chair, had to rush to the OR, but we will manage without him. Then later on, he joins us. So we have two very prominent speakers of the field tonight with us. Professor Frank Martin Haecker from Basel and St. Gallen, and Hans Pilegaard from Aarhus, Denmark. So we will start with Professor Haecker. He has several affiliations. Actually, he's currently working as an attending surgeon at the departments of pediatric surgery in St. Gallen and Basel. For years, he has a special interest in the treatment of chest wall deformities, studied medicine in Tübingen, Germany. And after his surgical training in Tübingen, Baden-Baden, he became consultant and later in 2014 professor of pediatric surgery at the University of Basel. And 15 years ago, in 2007, Professor Haecker has started a specialized outpatient clinic for chest wall deformities in these institutions. And he's mentoring actually the world's largest series of Pectus Excavatum patients treated conservatively using the vacuum valve. In 2018, he took an interesting step in his career by serving for 2 years as a consultant pediatric surgeon in Dubai at the American Hospital in Dubai, and served and started actually a new Pectus program in the Emirates. Apart from chest wall diseases, Professor Haecker has an interest in urology, and since 2018, he's a fellow of the European Association of Pediatric Urology. So coming back to the Pectus topic, Professor Haecker is founding member of the Chest Wall International Group and member of its executive committee. He was president of that society from 2018 to 2021. So Professor Haecker, dear Frank Martin, it's a great honor to have you with us this afternoon. And we are curious to listen to your presentation.
Well, Martin, thank you very much. Thank you for the kind introduction. Thank you for giving me the opportunity to talk about our experience with surgical repair of Pectus Excavatum. And I'm more than happy than you already mentioned. I think I'm pretty well known for conservative treatment of Pectus Excavatum. So I'm happy to talk today now about surgical repair. And the topic of our talk is short bar versus intermediate or long bar. So just to introduce, I never had a greater serious experience with short bar. It's not why we were not convinced to use this, it's just we don't have so many patients that we can do so many different techniques. I have nothing to disclose, no conflict of interest with any implant company. So preparing for this talk, of course, you have to go back to the history, and the history when you're talking about minimally invasive repair is this fundamental publication paper. It's now more than 20 years old, from Donald Nuss and his group. And still today, the interesting thing for me is that when they published their paper, they talked about their 10 years experience. So that means they started with the Pectus program and the Pectus repair in the late 80s, and they published their experience in the late 90s. And I think the majority of you know this figure, this graph, and all Pectus surgeons who do Pectus surgery may be aware that this graph is not completely showing all details. But I went back, so in preparing this talk, I thought, okay, I have to go back to the roots and look what type of bar, what length of bar Donald Nuss presented in his original publication. And you see two interesting figures from this paper. I think interesting figures in my personal experience, because you see it's something like an intermediate or a long bar, but it's also interesting that even in this very early publication, they demonstrated the technique of some type of bridge fixation, and I will come back to this later on. The second step, preparing this talk, I thought, okay, I'm going back. What is our experience when we started? I think we've been one of the first surgeons in Switzerland, starting with the pectus repair now then more than 20 years ago. And after 2 years, we published our first experience with the first 35 patients who underwent surgery in Basel at this time. And there were 3 or 4 major complications. The number one is the bar displacement, of course. And when you're thinking about which type of bar you should apply, which length of bar, I think bar displacement is an important aspect. Hematothorax, pneumothorax, and reoperation in connection with the bar displacement. And of course, in our first experience, we had all these horrible cases. And I think everybody who is honest with his own figures, with his own data, would agree that we all make mistakes, but mistakes are to improve our experience and to avoid, not to repeat the mistakes. So you see just a couple of our first patients. On the left side, the bar displacement in the horizontal plane, what we call also shifting. So the bar left the stabilizer. In the middle, pneumothorax from the Marfan syndrome patient, and on the right side, the bar slipping or bar shifting downwards. So today, if we are talking about the NAS procedure, and I'm wondering all the time, at least at every CVIC meeting, you see different talks about surgical repair, and you see completely different images, completely different type of implants. And I will show you. So I think for the majority, the standard is 1 pectus bar with 1 stabilizer. Some people apply 2 pectus bars with 2 stabilizers. And depending on the patient's age, some people also apply 3 pectus bars, sometimes with or without stabilizer. And that's the topic of Hans, just to mention the complete, so about the short bar. But if you continue, sometimes you see a situation like this. So that is a multiple bar placement, and it's not the multiple bar placement, also the so-called crossbar technique. And you see, that's one of the advantages to use intermediate or long bar. If you want to connect and fix these bars with a bridge technique, in my personal experience, the patient will feel more comfortable if you have an intermediate bar, not ending here, but on the lateral aspect, and you can connect these bars with a bridge technique, and that will increase the stability and decrease the risk of secondary displacement. Coming back to the original publication from Donald Nass, I think a very important aspect is age of patients at time of surgery. You see on the left side, that's the figure from his 1998 publication, and you see that the majority of patients who underwent pectus repair within this 10-year period were under the age of 10. And 10 years later, you see as a significant age shift to puberty. And during puberty, you will have a different growth situation than in pediatric patients and in contrast to adult patients. And that's, from my personal aspect, a very important aspect. If you're considering short bar or intermediate bar, you have to keep in mind and keep an eye on the patient's growth. And there is one aspect, I took this slide from Donald Nass. He mentioned 2 stabilizers should not be used in growing patients because they will cause an hourglass effect. And in my personal experience, the first couple of patients I showed you before, we had in 2 or 3 patients using the Longbar implant, we had this hourglass effect. If you do the surgery at the age of 14 or 15, and these patients are in the middle of their pubertal growth spurt, you may have the risk of the hourglass effect, either with 2 lateral stabilizers or only with the Longbar. Bar selection, again, I have no conflict of interest, so I will show you just a couple of convenient and popular implants. I think many of you know the implant of Biomed, and there is a new design that's already available in the US market. They changed the system with the connection with the stabilizer and also adapted the screw system. On the right side, it's from MedExpert, it's from a German company. And also for this company, it's in my personal experience, it's better to use an intermediate or long bar, but I prefer the intermediate bar because you can put the stabilizer on the lateral aspect and the stabilizer will be fixed with a screw. I used a couple of times this implant from a French company, and that's in my personal experience also the intermediate type, and you have a complete connection with some type of stabilizer, and it's very good applicable, especially in very tiny female patients. And on the right side, you see the primate implant. It's from Dr. Park. It's a very famous pectus surgeon from Korea who developed his own system, including this bridge system. So bar selection and configuration, we prefer the intermediate length of the bar. And for that, you should have in the middle a tile bending, not too sharp. And for us, a landmark to select the appropriate size. You go in the middle, you have the frontal axillary line, you have the medium axillary line, and the tip of the bar should be in the middle, in this like this. So the bar has some stability that decreases the risk of secondary displacement. And also you can, on the lateral aspect, put your stabilizer. It's not on the frontal aspect, which is sometimes obviously seen. And it's also not on the completely lateral side, where sometimes it's disturbing in movement of the upper extremity. What are for my personal experience, the most important aspects when you think about the bar, the type of bar and the length of bar? Infection, I think there is no difference between the different lengths. Just for completeness, if you think about infection, be aware that sometimes you may have also allergy. Horizontal shifting I already showed you. And of course, dislocation of the bar flipping, that's what we are afraid of and what we should avoid. And when you're going back to the literature, this is a publication 15 years old when most of the European centers and other the US centers published their first experience. So 15 years ago, secondary bar dislocation was a very common phenomenon. If you see here in this table, 27%, even in the group of Dr. Nass, 10%, European multi-center study, 11%, only Dr. Kark was below 10%, and again, two others with between 15 and 20%. And displacement means in the majority of patients, you have to do a redo surgery. So the recommendation is proper fixation, and you do these pericostal wires. You can do the wire around the bar and the rib, and you can do additional fixation between the bar and the stabilizer. And finally, you do a fixation of the stabilizer on the skin. And you will increase the stability if you select two separate ribs for fixation of the bar. But however, you have to be aware that even in this situation, sometimes we have an image like this, and that means you have to do reoperation. So to avoid this, Dr. Park, and as I tried to show you, also Donald Nass in his first publication already mentioned, but Dr. Park from Korea introduced the so-called bridge technique. And in my personal experience, the bridge technique, for that you should use the intermediate bar. I know you can also use this with short bars, but I prefer to use the intermediate bar length to bring the bridge on the lateral aspect. And if you do this, you can do different applications, and depending on the shape and the degree of the deformity, it might be useful to apply this crossbar technique or parallel bar technique, or you can also combine crossbar with parallel bar technique in patients with complex deformities. And as I've already shown you, sometimes you will have 3 bars, 4 bars. I've never seen a patient with 5 bars, but I've seen a couple of patients with 4 bars. Again, it's dependent on the patient's age at time of surgery. Bar selection and configuration. Bending the bar, avoid excessive bending in the middle, and also avoid excessive bending at the ends, because you have to be sure that the stabilizer will be slip on the bar, that you can fix the stabilizer with the bar with enough distance. One more, for my personal experience, important argument to use the intermediate bar is the skin incision. If you have a short bar, of course, you will do the skin incision more in the frontal aspect. If you have a long bar, you will do it in the lateral aspect. And if you have the intermediate bar, you do it in between the frontal and the middle axillary line. And I hope you agree that in this patient, you will see nearby no scar formation. So that's a very convenient and very comfortable technique to avoid severe scar formation. And in many of my patients, you don't see any major scar formation. So just to summarize, patient's age at time of surgical repair is for me important for selection of the appropriate bar length. And of course, you have to have an opinion, an idea whether you want to implant a single bar, 2 bar, or 3 bars, and whether you want to fix it with or without a bridge technique. And as shown with the slide before, skin incision, it's for me a good argument to use the intermediate length. Then you have, especially in female patients, you have nearby invisible scar formation. And I thank you very much for your attention, and I'm wondering what Hans will tell us about the short bar technique. Thank you.
Yeah, thank you very much. I'm introducing the second speaker of this afternoon, which is Professor Hans Pilegaard. He does not need much of an introduction. He's one of the pioneers and giants in the field. Graduated from medical school of Odense University in 1977, graduated there, and then underwent cardiac and thoracic training in specialization until 1993. He was appointed as a consultant for thoracic and cardiac surgery at Aarhus University Hospital. After retiring from this position in 2016, he remained assistant professor in surgery at that hospital and now works in a private hospital called Elaris Hamlet in also Aarhus. He's also traveling around the world and teaching and helping other surgeons with the NASP procedure. Professor Pilegaard has a vast experience in cardiothoracic surgery with unbelievable numbers, like 1,000 heart operations, over 5,000 general thoracic procedures, 2,000 corrections of Pectus Excavatum, and 250 repairs of Pectus carinatum. On the scientific side, he has authorized chapters in 15 books, contributed to over 100 chapters, and he has chaired a lot of societies, including the Danish Society of Thoracic Surgery, the Danish Surgical Lung Cancer Group, and he is member of the Chest Wall Interest Group, the CIVIC, where he's also, like Frank Martin, on the executive committee. And he has been president of that society between 2013 and 2015. So we had here in Leipzig the honor to have Hans Pilegaard also as a visiting professor for quite some good cases here in 2018, which all went very smooth and had a speedy recovery, and also speeded up our own Pectus program, which we are very grateful for. So Hans, it's a great to have you with us here tonight, and we are looking forward to your talk.
That's fine. Yeah. What I will talk about is the position of the patient. I will be quite take it as a surgical point, how we do it, how we can make, in my mind, the best stable system, and how the bar should be shaped and in which position we should put them. What's that? It's a, so if we look from the original position of the scope, it was in the lower end, but I don't think that's the optimal part, because there might be a risk of make lesions to the diaphragm. And also, well, I show you in the next slide that you don't have the same good view, in my mind, as if you put your scope higher. And also that the arm is above the head, because then you can move the scope from side to side. It's also very important that the patient is totally to the right, so you can go down with the scope and look at the anterior wall of the chest inside. So if you have the scope in the low position, you will see you have a lot of diaphragm. If you put it higher, you have a much better view. You have the diaphragm here. So I think that's the optimal position of the scope. When I started, I of course used the original technique with a long bar, 2 stabilizers, but I was wondering why we needed such a long bar, because it was going from the mid-axillary line to the other mid-axillary line. What we need is only, in principle, a short bar, because it should push the sternum in front, but such a short bar, it's not very stable laterally. What I've found out, because I changed. So you can see I used a short bar with 1 stabilizer. In the beginning, also the shooters around the bar and the rib. But we found that with a short bar, and if the rib was quite horizontal, there was a risk that this end would drop into the chest. So therefore, today I use, you can say, an asymmetric bar, which is longer on the side where you don't have the stabilizer, as you see here on an X-ray. And if you put the bar outside the chest, you can see we have a longer end opposite the stabilizer. But I will show you a little later at slide where you can see why I put the stabilizer here, because I think if you have the stabilizer on the lateral side and you have the turning point here, it will not stabilize very good. Another thing is, if you want a good stabilization, is that you go in and out of the chest cavity medially to the highest point. Another thing is that the bending technique, I prefer that you may say bend, so you error correct, because when you put the bar in the chest, there will be some debending, and I can illustrate it with these 2 pictures here. This is the bar I put in the patient, because I used the same incision for 2 bars. I put this bar in first, and then I put another bar, and then I removed this bar, but it was looking so. So therefore, I think it's very important when you bend the bar that you do error correct in some way. You also have to take into account asymmetry. If it's go to the left, you should put your stabilizer on the right side, because there is a better plateau, a better ground for the stabilization. And if it's go to the right, you should put it on the left. And normally I prefer to have it on the left. And the other thing what I talked about was the position of the stabilizer. As you see here, that's the original. You have the stabilizer laterally. You can turn the bar because you have the turning point here. If you, instead of that, put the stabilizer medially, you can see it stabilizes very, very good. So therefore you get a very, very good stabilization. And what I forgot to say before, when I have that asymmetric bar, this side opposite the stabilizer is working like a hook. So if you retract that to the chest side and you put the stabilizers medially to the exit, you will have a very good lateral stabilization. And where should you put your bar? You should always, or in most cases, support the deepest point. You mark where you have the possibilities of intercostal rooms. You put your scope in and you look for the deepest point, and you can follow the line of the scope. And to see if the point where you want to have the bar under the deepest point is okay, you can push your finger on the spot on the chest wall. You can see if it goes in the direction of the deepest point, then it's okay. So in most cases, you will see an horizontal bar, asymmetric placed, with one stabilizer fixed to the bar with a steel wire, and I don't use any shooters at all, because this situation is very stable, because this longer leg is doing that it can't move laterally. And another thing why this end should be a little bit longer is that over here, the stabilizer will be on 2 ribs, so therefore you also need a longer end at this side, so you have it on 2 ribs. And this is a high and a low bar. I will be back in that. And what do we know about the number of bars? We can see that, as Frank Martin mentioned, we don't put bars in patients below 11 years, but we think that the optimal age is between 11 and 13 years. And our median age is about 16. And you can see if the patient is younger than 18 years, most of the patient only need 1 bar. But if it's older than 30 years, most of the patient need more than 1 bar. 80% need around 2 and even 3 bars. And what I think is the big challenge of this procedure is when you have a very deep pectus. You can see here on the, okay, forgot to close the noise, but you can see how deep it is going. So if you try to get your introducer under here, you will probably be in risk of perforating the heart or making lesions to the heart. So what do we do when we have a deep excavation? We know we always need more than 1 bar. So in my technique, I put the first bar higher than the deepest point, and often at the level of the nipples. And why do I start there? I put the first introducer up there. And when you elevate that part, you will also elevate the deepest point. So it's much easier to get under the deepest point. Another thing is when you have your tunnel up here, you might enlarge it down without problems. I will show it in a slide in a little later. The distance to go when you have made your tunnel is under the other side is very short. You can see when you have the scope quite low, you can look to this area, and then you only have 2, maybe 3 centimeters to go for doing the rest of the tunnel. Another thing is that it might be a good idea to use a harmonic scalpel if you don't have so much space. You can cut into the mediastinum, and you can make your tunnel totally by cutting and dissecting. It's easier to work with than the introducer. So you do your whole tunnel work with the harmonic scalpel, and then it's very easy to put your introducer in. You can see. You can also see where you get out, and put the first introducer in. Another thing is that you have to use a optimal introducer, so you always are in contact with the backside of the chest wall with the tip. So you have the large one and the extra large one, because I think the small one is too, it's not rigid enough to handle our patients with. Another thing you should avoid is stripping, because when you come to the left side, there is a risk that you strip the intercostal muscle. The risk is not very big with the large introducer, because when the tip is through the skin, you can push because then you will just go above your rib. But if you use the extra large one, and you only have the tip through the skin and you push, it will work like a machine, so you have some stripping. So therefore, it's a very good idea when you use the extra large, and you can even do it if you use a large one, put a steel wire in the eyelet and elevate. And you can see here what also is, so you have your assistant just to pull up, and then you like pumping movements, you gradually elevate the sternum and you can push your introducer through the patient. Here was a patient, the first introducer, and you see that the deepest point now is elevated quite a lot. And why it's a good idea to start more cranially, you can see here, that's a high bar, or the high introducer, let it stay, because the introducer is also more rigid than the bar, so it's very good to have the introducer in the patient. And you can see you can just move and you can get a very big tunnel, so you don't have any risk of making lesions to the heart. And you can see here, when I use a high bar, I prefer to make a small incision around the nipple because I want my stabilizer here in the midline. It's very difficult to get up from the side. So I just make a skin incision, split the muscle, so I make a pocket beneath the pectoral muscle. And you see here how it looks. A very small incision, you can hardly see it, and a small incision after. Another trick when you should put the stabilizer on is that before you turn the bar, you put a steel wire around, turn the bar, and then you can use this steel wire to elevate the end, because sometimes it goes between two ribs and compresses the intercostal muscle. So it might be a little bit difficult to get the stabilizer on. Therefore, you can use your steel wire to elevate the end of the bar and put the stabilizer on. And you can use crossbar. I introduced that in 2015 if you have a very short and narrow, and it can also be used in other cases. I know that Dr. Park now is very pleased with that technique. Sometimes you have that the rib is just where you have the deepest point, so you can't get under the deepest point if you go just across. But then if you go entry just on the intercostal space caudally for the rib and come out, exit just cranially, you will just have your force just under the deepest point. So you have this construction. And then you should be aware that if you have this direction, you should put your stabilizer on this side, because here this end of the bar is quite perpendicular to the ribs. If you do the other way, you should put your stabilizer here. Sometimes you need two parallel bars, and in some cases this part is elevated too much, that's around the C4, then you can use the same exit on one side. Another thing is that it doesn't matter that you have the two stabilizers at the same side. It might be a good idea, because sometimes the upper flap from the system we have now is a little bit too short, so there is a risk that it will turn between two ribs. So if you put this flap above the lower flap on this side, it works like a bridge. You can even use it if you have excavation in the lower part with a very, very oblique bar. So you have a lot of possibilities. Thank you for your attention.
Yeah, thank you very much, Hans. That was also a beautiful talk. Where is this picture, the last picture?
It's not from my window, but it's close to. I'm not living to this lake, but if you sail this way to the right, I living about 2 kilometers from there, and I can see the next lake. We have a lot of lakes here in the area where I live.
Beautiful.
Beautiful. So please, all the audience, type in your questions in the chat. You may start now. I don't see any from the audience. Then maybe Augusto, do you want to start?
Yes. Can I start with a question? You know, we do see a lot of patients as pediatric surgeons that are, of course, teenagers and come with Pectus anomalies of any kind. But I have no experience with adults, and I've seen that in your one of the first slides you had a picture of patients that are also over 30 years of age. And I'm wondering whether these patients had any symptoms or whether it was like something that it was a like clinical indication. But I'm also interested in the results, because we always try to fix the issue when patients, as I said, are teenager, because allegedly the rib cage is more pliable. What are the results in these ones that are actually older?
I think they are quite good.
Sorry to interrupt. Can you end your presentation, because then we can all see each other again? Sorry.
You can stop the sharing.
I stopped sharing. Okay.
You know, I'm asking this question because sometimes the parents ask whether they can wait until the child is not a minor anymore and later. And my comment is always that it's better when you do this kind of surgery when they are teenagers, when they are younger. But you were saying that the results are pretty good.
Yeah. I can tell you, of course, I also prefer to do the patients when they are teenagers, because they are so soft in the chest wall, and it's not a problem to correct them. But when we started to do the NOS procedure, it was in 2001. We haven't corrected any patients with Pectus before. I think maybe one or two in the period before. I started in the department in '86, and I remember only one case, so we didn't have any experience with the rabbits procedure, and we started with the NOS procedure. And of course, we knew from the beginning that it was only from teenagers. But then we gradually increased and could see that, okay, if they were 20, 25, no problem. 30, no problem. 35, no problem. But when they get 40, 45, 50, there might be, they are more rigid. But then you, of course, should use more bars. And I think with the technique, what I showed you about the pumping, so you gradually increase, you can say, the pressure from behind of the sternum, you can do a proper job. I can tell you that the oldest patient I have done was, I was to a meeting in Saint-Etienne, and then they asked me to do some light surgery, and said we would do some adults. Yeah, no problem. They found a 64-year-old previous GP, and I was a little bit afraid that we couldn't do it, but I said, okay, we can try. He had a lot of problems, a lot of symptoms, and we put 2 bars in. He was quite deep. Before, he couldn't go more than maybe 100, 150 meters. After, he could several kilometers, because the compression of the heart was removed. And even you can say the cosmetic result was quite good. But of course, there's much more work with it. But I think that of course, there might be some more complications. But when you get more experience about it, it's not a problem. And if you think if you think it's too difficult to just use the introducers, you might use a crane technique. Put a steel wire in the sternum, or maybe put a kind of hook under the sternum and elevate with the crane. And I think you can do it because I think that the wrap is okay. It's quite good, but when we look at the chest or the chest wall after, it gets more rigid. Even you produce new cartilage, you will see in a CT scan that it ossificates. So instead of have you can say acceptable flexible chest wall, we will now have an unflexible chest wall because it's like a wall. So therefore, I think if we can, we should avoid to remove any cartilage in the patients. And I have published several years ago a paper about add-ons more than 30 years, and at that time I didn't find any more complications, and especially there was no problem with flipping because I put my stabilizer where I do.
Okay, there's one question from the chat. Maybe it goes to Frank Martin first because he's doing the vacuum belt treatment also. So one delegate is asking any criteria that you use to assign the patient for bar treatment. So Frank Martin, when?
So, sorry, to assign the patient for what?
For the NAS procedure, for the bar treatment. I guess that's a question, right? So what is your criterion?
So I would like just to comment or to add and confirm what Hans already said. If you do surgery, the patient should not be too young. So because also patient's compliance is, in my personal experience, very important for the postoperative course. And on the other side, we as pediatric surgeons are privileged in comparison to thoracic surgeons to see the patient at a comfortable age. So, and when we started, I tried to show you, we started in 2000 with the NAS procedure, and we started 2.5 years later with the vacuum belt. And I think many of us had the experience before we had the NAS procedure. We didn't see so many patients because the majority of patients, you had only the open repair, the ravage procedure, and it's some like major surgery. You have a big scar, you have this cardiac resection, you know what will happen with these patients later on. So in my personal experience, we didn't have so many patients. And when we started with the NAS procedure, that was the first. And then we started with the vacuum belt, and the number of patients increased significantly. And at that time, it was really difficult to assign who of the patient will be appropriate for surgery and who of the patient will be more convenient with the vacuum belt. So now, after a couple of years, we try to convince our general practitioners and pediatricians to refer the patients at an early age. So if you see the patient with a mild degree of pectus at the age of 6 or 7 years, you may consider them for conservative vacuum belt treatment. And then it's important, in my personal experience, to follow up these patients, because we know there is always a worsening of the condition during puberty. So, and if you have a patient with a mild degree of pectus and he is successful with the vacuum belt treatment, you will just see them for every second or third year just for follow-up. But there are about 10 to 15% of patients in whom vacuum belt treatment will be not effective, or you see a worsening or something like a recurrence during puberty. And the majority of these patients, they don't feel comfortable to restart with vacuum belt treatment. And we also have to be aware the majority of these patients are male 14, 15-year-old boys. Mm-hmm. And we see it many times in our outpatient clinic that the mother is sitting on a chair and try to convince her son to please go on with the vacuum belt and you may avoid surgery. But the boys, they just tell you, forget it. Either I stop treatment or I will go ahead for surgery. Mm-hmm. Yeah. So for me, there is only a small number of patients in whom you just separate between conservative or surgical. We see in the meantime, we see the majority of patients before puberty. And then we can demonstrate what would be a good option for conservative treatment. And about 80–85% are interested and they start. And about 10 to 15% of these patients, especially male patients, will not be successful. And the majority of them, you don't have to discuss to continue with surgery. They are interested, they want to have their chest wall fixed. And the majority of them are asking for surgery.
Okay, there's another question in the chat. This is from Dr. Soldatankova from Riga. Two questions, in fact. One is, are there differences in postoperative period in short versus long bar groups in score management, patient activization? And do you use CO2 insufflation during the operation to improve interthoracic space and visualization?
So maybe I can just comment. So we use the CO2. When we started with the procedure, we had double lumen tube and we had a lot of things, and the preparation of the patient took nearby the same time as the procedure. And then we stopped with the double lumen. We just have a single lumen intubation, and we use the CO2. And the number two, I can compare the difference between short bar and long bar. I just can compare between long bar and intermediate bar. And as I try to demonstrate, we feel much more comfortable with the intermediate bar. Because if the patient is growing, it's not only the length, it's also in the deep. So if you put the intermediate bar, you just place it in front of the chest wall, it will grow and will not have any hourglass effect. But maybe Hans can comment on that, because you started with the long bar and you switched to the short bar.
Hans, you're muted, if you can.
So, can you hear me now?
Yeah.
Okay.
Yes.
Yes, I started with a long bar because I was teached to the long bar. Then I thought, why should it, as I told you, why should I use such a long bar? But then I found that a really short bar was maybe too short. So you see now, my bar where I have ended is, I think, something like an intermediate bar too, because it's longer on the opposite side than it is on the side where you have the stabilizer. And I think I again will change now when we have the possibility to put the stabilizer wherever we want, because now we can put the stabilizer with the new system. I haven't tried it, but I saw it at the annual meeting now we had in Barcelona. You can put it in the front and even have a little longer bar. So I think I would like to use, you can say, an intermediate bar and make a small incision in front of the patient to put the stabilizer there. Another thing is that, as I told you, that the old stabilizer, it was a symmetric one, and sometimes one of the flaps, normally the upper one, and you can change it whatever you want, but was too short. But now they have made, because I've asked for that in several years, an asymmetric stabilizer with a longer flap on one side and a normal flap on the other side. So I think that will minimize too the risk that the upper flap could go between two ribs and the bar should flip. And with my system too, they can grow, because you will never see a clock form, because on one side it's shorter, the length of the bar is shorter, and if they grow and get wider, it will retract the bar to the side where you have a long leg. What I think concerning where you put your stabilizer, I think my technique gives less pain, because we can see that 85% can leave the hospital on day 2 after surgery. And I think that might be because you have a more stable system. If you put your stabilizer on the lateral side, it's not so fixed. So there might be more movement when you breathe. But now, when you have the stabilizer medially, it's so fixed that it can't turn. So I think that's a very good idea too.
Yeah, I agree. From what lessons you told us, if you really put the stabilizer so medial that it can flip, that really worked.
Yeah.
I got another question here. I think Frank Martin mentioned allergies. Could you both comment on how do you deal with the myth of nickel allergy and what experience you had? Do you test for allergies prior to the surgery and so on?
I think I can start because I put the normal steel bar in the patient even though they have nickel allergy. And why do I do that? The first, it was in the beginning of our area. So to do the nurse procedure, suddenly the mother called us a couple of days before surgery of her son. Oh, we forgotten to tell you that he has nickel allergy. And I was thinking, okay, my God, what do we do? Because we can't get a titanium bar with such a short time period. So I asked the dermatologist and they said, don't mention it because nickel allergy is a contact allergy. You should put it on the skin. If you put it inside the body, there's no problem. So since that, I have never used a titanium bar without when I visited you because you had to in Leipzig. So I don't think it's a problem. And you can see we have done more than 2,000 cases in Aarhus, and I personally have maybe used about 2,500, 3,000 bars, and it has not been a problem. So I don't think that the cases we have had of infection is caused by allergy. I think it's caused by other things, because when in the beginning we had some very late infections after surgery, we only gave the patient one shot of antibiotic, and then we changed and gave them 3 days of intravenously. And after that, of course, we will have infections. So it is with all surgery, but it's less than 1%. So it's a very low rate.
Okay, thanks for sharing this, Martin.
So we fortunately we have within 23 years never a case where we had to remove or revise the Pectus bar due to allergy. But we take patient's history, and in case if there is a positive patient's history or family history, we send the patient for a specific allergy testing. And I think in total, as far as I remember, we had 4 or 5 patients in whom we had to use the titanium. So we were not tough enough to just to disregard this recommendation. But it's in our experience, it's only a minority of patients in whom you have to have the titanium bar.
Okay, we have, I think, the last question in the Q&A, which is about the reservations regarding the use of MRI scan after the bar placement. Do you have any reservations in using MRI scans?
No.
No.
No. I tell the patient they can go to the MRI scanner without problems. There might be like, if you put them in the CT scanner, there might be some change things, but else it works very well.
Perfect.
I may just may add a funny history. In Basel, one of our patients, it was the daughter of the security boss at the airport. And then he left the hospital and he checked all his 25 or 30 different security check points at the airport. And the interesting thing was that about 40% of the machines indicated the foreign body, but the remaining did not. Oh. So we provide for every patient the implant card for that. But it was interesting for us to see that not every machine is searching for the same.
That's scary.
That's scary because 60%, almost 2/3, did not detect it. So it's but a very thanks for the anecdote.
We have the same experience when we talk to the patients that a lot of them just go through the security without making any alarm.
Interesting. It's different for hip replacements, and although it depends, of course, what kind of material you use. But well, thank you very much for sharing your vast experience. I think that we are 5 minutes over the hour. It was 2 great presentations, and thank you very much for sharing your experience over so many years with so many patients. I think this was the last webinar of 2022. So we're gonna see each other in 2023. So happy holidays to everyone, and happy New Year. Thanks, Gaia, for arranging this, and thanks to Professor Pilegaard and Haecker for joining us, and thanks, Martin, for co-sharing. And sorry if I was late. I was in the OR.
Yeah, and thanks everybody also from my side. I just put in the address of our YouTube channel in the chat. Please subscribe to this channel. There are over 1,000 subscribers of the channel now. So this edited webinar will be placed on that channel. So within the next year, I'm sure a lot of surgeons will watch it, and you can also track the further ongoing of what we did tonight.
Thank you for the invitation. It was a great pleasure. And thank you, Hans.
Thank you.
Great discussion.
Thanks.
Looking forward to seeing you in person at EUPSA next year.
Yeah, thank you very much for me too. Merry Christmas and a Happy New Year to everybody.
Yes, thank you for you also.
Bye.
Bye-bye.
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 Bye.
Die Schöpfung von neuem Leben ist wirklich beeindruckend. 2 Zellen treffen aufeinander, verlieben sich und werden eins. Diese eine entstandene Zelle beginnt dann, sich in Millionen von Zellen zu teilen. Sie bilden ein Herz, ein Gehirn, Beine, Arme, Augen. 9 Monate später ist ein neuer Mensch bereit, die Welt kennenzulernen. Wenn man darüber nachdenkt, ist es wirklich erstaunlich, wie häufig alles wie geplant verläuft. Aber manchmal eben nicht. Etwa 3% aller Babys werden mit einem Geburtsfehler geboren. Spina bifida und anorektale Fehlbildungen sind 2 angeborene Erkrankungen, die häufig zu einer Darmfunktionsstörung führen. Es kann auch andere Ursachen für eine Darmfunktionsstörung bei Kindern geben. Das Ergebnis ist jedoch dasselbe. Das ganze Leben ist auf den Kopf gestellt. Eine endlose Geschichte von Verstopfung, Stuhlinkontinenz und Problemen beim Stuhlgang. Den meisten Eltern macht es nichts aus, ihrem 8-monatigen Baby die Windeln zu wechseln. Wenn das Kind aber 8 Jahre alt ist und man es immer noch tun muss? Wenn das ihr Kind wäre, wären sie an einem gewöhnlichen Tag ständig in Sorge, dass ihr Kind sich in der Schule in die Hose macht. Und würden die meiste Zeit, die sie zu Hause verbringen, dem Management von Darmproblemen widmen. Sie würden ihrem Kind mehrere Stunden auf der Toilette helfen. Sie müssten die Folgen von Stuhlinkontinenz durch Putzen und das Waschen von Kleidung beseitigen. Sie würden neue Ernährungsweisen oder stuhlverändernde Medikamente testen, ohne Erfolg. Und daneben auch Zeit für den Rest ihrer Familie finden. Sind Sie schon müde? Dann bricht ein neuer Tag an und es beginnt alles von vorne. Es ist ein schwieriges Leben für sie. Und es ist noch viel schwieriger für ihr Kind, das an Schmerzen und Blähungen leiden kann. In der Schule möglicherweise Windeln tragen muss und ständig Sorge hat, sich einzukoten, was zu sozialer Unsicherheit führt. Das ist nicht das Leben, das sie sich erhofft haben. Wir sind der Meinung, dass Kinder stundenlang mit Freunden spielen sollten, nicht Stunden auf der Toilette verbringen. Wir sind der Meinung, dass Kleidung nach dem Sport gewaschen werden sollte, nicht nach Stuhlinkontinenz. Wir sind der Meinung, dass Teenager wegen Liebeskummer leiden sollten, nicht wegen Darmproblemen. Auf diese Weise tragen wir dazu bei. TAI, transanale Irrigation. TAI kann eine erfolgreiche Therapie für viele Kinder und Familien sein, die mit einer Darmfunktionsstörung leben. TAI kann die regelmäßige Darmentleerung wiederherstellen und Kindern dabei helfen, den Ort und den Zeitpunkt dafür selbst zu bestimmen. Dies verleiht ihnen Selbstvertrauen und ermöglicht es ihnen zu spielen, an Aktivitäten teilzunehmen oder einfach Zeit mit Freunden zu verbringen. So sollte das Leben eines Kindes aussehen.